We are waiting on your direction.
We ready? Dr. Brown, are you ready? All right. We're going to call this Board of Commissioners meeting to order at 4:08. We have a call to order. Need a roll call?
Commissioner Winfrey?
Here.
Commissioner Brown? Commissioner Shoemaker?
Present.
Commissioner Kuzno?
Here.
And Commissioner Flewelling.
Present.
We have a quorum. All right. Any public address to the board? Any public address to the board? No public address to the board. All right, on to communications. We have the EMS June 2025 preliminary report. And with that, I will turn it over to, if you'd announce yourself when you come up, and everyone else, that'd be, as they come up, would be appreciated.
Absolutely. So I'm Dr. Heatherlyn Uphold with Michigan State University here in Flint.
Dick Sadler, I'm an associate professor at MSU.
Nicole Smith-Anderson, Greater Flint Health Coalition.
Alan Harris, GIS analyst, MSU.
Hi there, Ryan Rees from Fenton, also on faculty at the University of Michigan, emergency physician and EMS physician.
A little bit of everywhere. Yeah.
One more.
Oh, of course. I'm sorry. We want to jump into the information.
He was fading in the background.
Jim as well. All right, so we're going to walk through kind of the format that we use to do the evaluation. We'll go through some of the methods, and then we'll get into some findings, and collectively, we'll go through a discussion of interpreting the data and translating it together, and then we'll talk about some recommendations and action steps that we can take together, and that's the theme. And I hope that it really resonates, because we aren't dropping this evaluation off and then walking away. We all live in the area. And so this is something that we're committed to. So when we think about EMS, EMS provides urgent pre-hospital medical care, everything from when you pick up the phone to field stabilization and transport to the hospital. When we look at EMS nationally, they respond to about 50 million of the more than 240 911 calls yearly. And what we see is that EMS functions as both a public safety net, but also a frontline crisis responder on our worst days, right? But then when we apply this to looking at the actual steps, so this is an infographic that we created for the study. These slides will be available to all of you just for further digestion and understanding. You can see that we take things from detection all the way to reset. And Ryan, do you want to walk us through that?
So at the top we have detection, so an emergency situation is experienced or is observed. So you see someone fall on the ground, like myself, you see someone get into a car accident, you call 911. You access the emergency EMS system through the 911 service. So 911 is called, and so that system is activated. Where it gets a little bit confusing is whether the person who's injured or is having the medical emergency is calling, or if someone's calling on their behalf. Regardless, some basic information needs to make its way to the 911 center to appropriately dispatch the right resource to that medical emergency. So based on the information that the 911 center receives, determines how critical they believe the patient or situation is. So an older person having chest discomfort is different than maybe a younger person who was having a headache, right? So an older person with chest pain is probably more likely to have an acute medical issue, and so that's dispatched at a higher priority than somebody else. So, and based on that, the 911 center dispatches resource to that area. When EMS arrives on scene, they assess the patient, they collect vitals, they talk to the patient, they talk to bystanders or family about kind of what's going on to try to figure out how they can best help the patient. Initial care is provided, so in a severe case like cardiac arrest, which we talked a little bit about, starting CPR and to resuscitate the patient and determine what the next step is, which is either they transport the patient or not. Most patients get resuscitated, taken care of, and are transported to a receiving facility, such as a hospital in our community. The patient's handed off to emergency department staff. The ambulance is then restocked, reloaded, cleaned out, and then is prepared for the next emergency, which is where a reset takes place. And so this is kind of the typical process every time the EMS system is activated through the 911 center.
Yeah, thanks for that. Just to give us a sense of what the bookends are of what we're looking at. So we have that, when we look at the national challenges, so the challenges that we're seeing in EMS across the U.S., we see issues with workforce shortage. These aren't going to be surprising, right? We see burnout, sometimes related to low salaries. We also see high turnover. There are infrastructure deficits related to outdated equipment and ambulances, and then siloed dispatch and data systems. These will come up again. We're also seeing a rising complexity of 911 calls. So it's not just a straightforward, heart attack. It's a heart attack on top of another issue, on top of some pre-existing conditions. And we also see that 911 is often not only underfunded, but excluded from health systems planning. So it's very siloed, and very often when folks do an evaluation of EMS, what are they looking at? Response times. Not necessarily, is the patient getting to where they need to go, the other metrics that go along with that. It's, did they get there as fast as possible? So this is what we see nationally. When we apply that national perspective, locally, we see similarities. We see that there are workforce shortages, we see call complexity, and a reliance on not only the fire department for support, but also police. We also experience local pressures related to economic disinvestment, environmental harm, and then certain population characteristics. So aging population, areas that are, high crime, those sorts of things. And we also see issues related to fragmented governance and contract variability that can complicate not only delivery of service, but also the accountability. And when all of these things come together, that's when we see increased demand, that's when we see strains on operations, and how the community views it, right? How the community views EMS delivery. So our approach, and I'm just going to go through this quickly because we really want to get to the meat of the data and the findings, but I want to do my due diligence in saying that we used there wasn't just a framework that you could pull off the shelf. So we made our own. It's based on Mahmood's work, which is integrates some work from the WHO. And then in early 2024, there was a joint statement from several national organizations related to emergency management and EMS. And they said, hey, you can't just look at response times. You need to consider the context in which EMS is being provided. EMS needs to be better integrated with public health. You need to pay attention to these SDOH, or the social determinants of health, which we'll talk about on the next slide, and look beyond response times. So the joint statement outlined 5 areas that talk about effectiveness. So is this what someone should be getting? Is this the kind of care that they should get? Is it safe? Is it safe not only for the patient, but also for the responders and the community in general? And are folks satisfied with it? Does the patient walk away saying, I got the best care that I should get? And are the clinicians and EMS providers happy with that, with their experience as well? And is it equitable? So folks living out in a rural community, are they getting the services that they need, as well as folks who are living in a city or a more urban area? And finally, are we making the best use of the resources that we have? So these are the elements that we took into consideration. I talked about social determinants of health, or SDOH. And usually you say, when you define SDOH, it's the conditions in the environment that you do life, where you're born, you age, you work, you worship, you play, and you go to school. But what we add to that are a couple things. It's where we do life together, because we don't live alone. We live in a community, and we're all experiencing and being impacted by this. And that includes EMS. So in our evaluation, we considered the drivers and the context in which EMS is being provided. So what's causing someone to pick up the phone? It's not just looking at the end result and looking at the response times and those sorts of things. That's a great place to start, but we also need to consider why is someone relying on EMS? Why are they calling 911? So those were the elements. We talked about this data earlier, and I couldn't wait to share with you. Some of the things when we consider the context in which EMS is provided, life expectancy is one aspect. And the map that you're seeing here is from County Health Rankings. It's from 2022, which I believe is the most recent data that we could get. The darker the purple, the longer you can expect to live. You may have heard in certain areas a number like 12 years, 14 years, or 16 years. Our analysis, which is based on census tract, which I'll have Dick or Al come up and explain why that's important, shows upwards of a 20-year difference depending on where you live, depending on your address. So we've included our references. There's also another resource that you can use from the Robert Wood Johnson Foundation, where you can actually put in your zip code and even your address to tell you what the life expectancy is. But that data is from 2018 and not necessarily based on census.
We oftentimes use census tract as a geographic unit because zip codes cross over various communities and can sort of wash out those metrics. Census tracts follow municipal boundaries, so that takes that into account, and that's, yeah.
He says it so much better than I do. So we included this little blurb so that when you look at the slides, you can see it. But we also looked at data related to mental health. This will come up later. So what you're seeing on the map here, the darker the blue or that green color, this tells you that folks are experiencing more poor mental health. And the way that this is assessed is they ask individuals 18 years or older and they said, in the past 14 days, how much poor mental health have you experienced? And so you can see that map is reflected here. We've also included data. This should be familiar. This is the MySUV, or the Michigan Substance Use Vulnerability Index. So this is published by the Michigan Department of Health and Human Services on their dashboard. And it's a comparison index. So it takes one county and compares it with the other 82 counties, or 83 counties in the state. And there are 8 indicators that are grouped into 3 different categories: substance use burden, substance use resources, and social vulnerability. And we look at where Genesee County is. It is the highest in the state for burden. So this is impact on individuals, overdose deaths, calls to EMS for overdose, those sorts of things. It is in the lower quadrant, in the lower rankings for access to care. These are the resources that could help someone who has a substance use disorder. So syringe services or treatment facilities. And when we look at social vulnerability, that context related to poverty, Genesee County is in the upper third, upper quarter. And then when we look at the Michigan Environmental, it's the MyEJ screen, the Michigan Environmental Screening Tool. Again, another database, another dashboard provided by the state. The darker areas of red reflect the higher cumulative environmental justice burden. So it's not looking at one individual variable, it's looking at them combined. And the variables are poor air health, or poor air quality, heavy traffic, and concentrated socioeconomic vulnerability. And you can see the map is displayed there, as well as the map of the state. Again, just references as we are moving forward to look at the EMS. And why these upstream factors matter. We talked about this because when you have mental health issues, chronic disease burden, and life expectancy issues, they drive the number of calls and the complexity of those calls. We also see that with social and environmental pressures, economic disinvestment, neighborhood vulnerability. Those things can increase EMS demand, as well as system reliance and misuse. So gaps in access to primary care, issues with transportation, when the MTA changes the way that folks use their bus passes, when it's no longer a paper ticket and they have to use a phone. That complicates their access to care. And behavioral health services, when we don't have an urgent care that we can send someone to through GHS, that complicates the system. And then this operational impact. It's, again, when these elements come together, that's when we see increased call volumes, inappropriate 911 use, and strain across the county.
All right, let's talk a little bit about EMS in Genesee County. So for context, there's a few stakeholders that I'm sure you may or may not know about. The first is the Genesee County Medical Control Authority, which is tasked with oversight of EMS, including protocol development, quality monitoring. It's jointly administered by the 3 hospitals as well as Genesee County Board of Commissioners. The Genesee County 911 Dispatch Authority, so it's a local government, body of local government representatives that come together to support the 911 system. In Genesee County, there are 2 911 centers. This one, the main one here in Flint, or Flint Township, I believe, as well as one in the city of Fenton. And there are a number of EMS agencies, including MedStar, MMR, Patriot, and Twin Township. The Genesee County Sheriff's Office operates a non-transporting paramedic division. Contracts, so this has been, or maybe still is, a controversial topic for some time. So Genesee County has 13 communities with a direct contract with a single EMS agency, and 1 community with a preferred contract. Some of the discussion about EMS contracts surround the interpretation of both the EMS Act as well as the 911 Enabling Act. The map on the left side, or would that be the right side of the screen, highlights the communities and which EMS agency that they have contract or an agreement with. So talking a little bit about the EMS Act and the 911 Enabling Act. So I'm paraphrasing for sure, and I'm certainly not a lawyer, but the EMS Act allows local municipalities to either operate their own EMS service or contract this out to provide for their citizens. So the language of the law states that a government unit may or multiple government units can work together, but they may operate an ambulance operation or a non-transporting pre-hospital life support operation, or contract with an organization to furnish any of those services for the use and benefit of its residents, and may pay for any or all the costs from available funds. A local government unit may receive state or federal funds or private funds for the purpose of providing EMS services. A lot of these contracts, I don't believe, receive municipal funding, and so they are funded by billing the patient when they transport or take care of the patient. The other act that we talked about with EMS contracting is the 911 Enabling Act. So this is the law that states that public safety answering points, or PSAPs, or 911 centers will dispatch the appropriate available public service, available public safety service unit located closest to the request for public safety service. So there's some ambiguity and there's some confusion about what it means to be the closest or the most appropriate. And so the 911, the state 911 committee put together a clarifying document called Policy E, which tries to define and give some guidance as to what appropriate and closest means. And so the second part here is from that and says that the 911 center or PSAPs need to give equal weight to the terms appropriate and closest when establishing dispatching policies. So if a municipality says that they have a contracted EMS provider, then they are the appropriate one to be dispatched, and that the PSAP should dispatch the closest unit of that provider or that agency. When we look at EMS statewide, So not just Genesee County, but some of our surrounding communities. EMS is typically better organized. You know who your EMS provider is. In the more rural areas of Michigan, EMS is typically organized by the county, so it's like a county EMS system. In the more urban areas of Michigan, the fire service has a more active role in 911 EMS responses and transports. And then there's sometimes a mix of the two. So communities elsewhere have a designated EMS provider if they don't use their designated fire service, or if there's a need to provide mutual aid to the contracted provider.
So that kind of sets the stage for what we're going to move into next, which is the actual data collection. So our approach, we used a mixed method approach. So we talked to folks, we did interviews, and we also did surveys. And then we also looked at data that was available from the state and then 911. So we did a quantitative systems level data examination. We also asked stakeholders their perspectives through interviews and surveys, like I mentioned. And then we did this contextual analysis. That's another way of saying we looked at the environment where EMS is provided. And our principles that drove it were community engagement, right? So we wanted to get that feedback to center local, not only local voices, but the experiences of the folks who are providing the services. And then make sure that we were building in some mechanisms for public sector accountability. And we'll get to this with a dashboard and some other ways that we can equip not only you all, but others to tell the story of EMS. Because it can't just be one person. If we're going to address this siloed issue, we need to make sure that the data and the information is in a package that folks can take it into other meetings and other environments and say, hey, this is how we break down these silos by taking the story of EMS elsewhere. And we wanted it to be equity-centered so that we could examine what are the structural issues that are built into the design of EMS so that we can make sure that no matter where you live, what you look like, or what you're doing, that we can get you taken care of in the best way possible. And then we did do that comparative data analysis and qualitative synthesis, and then we looked at those upstream drivers. This is where we got the data from. So we got the data from the state from 2019 to 2024, and we looked at call volume, call type, call volume, timing, provider, and geography. There were more than 1 million rows of data that were sent from the state. We also got data from the 911 consortium. We used national data sets, and then those stakeholder surveys. We did some interviews, and then we also did a media analysis that was included in the final report, just to kind of get a sense of how is the media portraying EMS in Flint and Genesee County. This is the beginning of a framework that we're developing for evaluating EMS. And as folks are interested in being a part of the development of this national model, we would always welcome additional folks at the table who want to help with a perspective. So consider that an open opportunity if you're interested. But this is how what we looked at mapped onto some of the key areas as we're building out this model. So we did a survey of elected officials. We received 36 responses. We don't have a response rate because we aren't quite sure how many people actually received it. Our findings related to service delivery, or service quality rather, drivers, system gaps, and recommendations. And this quote at the bottom really gives a sense of how some of the folks were feeling, that we need more coordination, more transparency, and a system that puts people, not politics, first. So EMS was viewed as a critical public safety function across all municipalities. Service reliability varied based largely on whether folks had an EMS contract or not. We couldn't do a full examination of the data just because the distribution wasn't equal. So we couldn't say, so X number of folks said, this and this was the significance. We couldn't get that deep, so we're just painting kind of a high-level picture. But folks who were contracted said, hey, I'm not having any complaints since we went into a contract, nothing but positive feedback. For folks who didn't have contracts, they say X agency is across the street, I can see them, but they don't get called. Instead, an ambulance has to come from about 25 miles away. This is not life-saving. And we also saw in non-contracted areas that they were reporting a delayed or inconsistent response by EMS, unequal resource distribution, and a strained not only fire department, but police, with them having to respond to calls like lift assists, calls like car accidents, and a wide range of things. When we asked elected officials what's driving EMS, what's causing people to pick up that phone, they said aging population, substance use disorders, chronic disease and mental health, and socioeconomic disparities and poverty. And these were causing the system strain concerns were staffing shortages, high call volumes, and use of EMS for non-emergency issues. When we asked elected officials their thoughts on the 911 authority, they felt that 911 was largely effective, 4 out of a scale of 5. They did a fine job prioritizing emergency calls as well as allocating the closest resources. Concerns were around over dispatching multiple units for non-emergency calls, so sending multiple EMS agencies when grandma, can't get up or something like that. Ghosting by contracted EMS, so disabling their AVL systems that indicate where the vehicle is, and then difficulty managing service contracts during dispatch, and then an issue related to the tiered response system. So previous to January 2025, roughly, 911 was on a 2-tier system. That has since changed. Oh, it still is? It hasn't officially changed?
It hopefully later this year.
Okay. Is in process. All right. When we asked elected officials about the med control, so their thoughts on med control, effectiveness was lower, rated lower than 911, so roughly in the middle. Key concerns were awareness gaps. We really saw that a lot of respondents had no idea what med control did. And in fact, you can see the quote here saying that 911 authority should be responsible for ensuring the laws and protocols are provided for every citizen. This is edging more towards what med control should be doing, but was attributed to 911. So there's confusion not only in what med control does, but what 911 does. So there's some bleed between there. There were also concerns about enforcement and transparency. So weak enforcement of protocols related to what an EMS or EMT can provide, the kinds of services that they can provide. There was also a perceived political influence for med control, as well as limited communication with municipalities. And this will come up in the interviews because it's actually bidirectional. So it's not just that elected officials want more information from med control, they also want the opportunity to provide input to med control. So it's both ways. The survey continued. We asked about EMS agencies. We saw positive experiences related to faster response times, better coordination, patient care improving. So concerns were related to inconsistent services, lack of transparency, and unequal distribution of EMS coverage. What's underlying this are the contracts. And then additional challenges related to confusion over roles, especially with overlapping services with the paramedics division, because the paramedics division is non-transport, meaning that they can respond to a call, they just can't take someone to the hospital. And then there were questions that came up about a system-wide coordination under the current operation model. This will come up again as well. When we asked about gaps and recommendations, like, okay, so what are your ideas? How can we fix this? How do we address this? Gaps were related to limited confidence or confusion around med control, coordination gaps between all of the entities. So dispatch, the agencies, med control, and oversight entities, and then this contract model causing fragmentation and inequities. And what they recommended was to explore a unified EMS strategy, reform EMS leadership and accountability, improve public education, and strengthen dispatch protocols and transparency. We then offered the folks who responded to the survey the opportunity to have an interview, and we did 10 individual interviews, but sometimes there were more than one person sitting in on the interview. And they included folks like mayors, township supervisors, and police or fire chiefs. Their primary concern was related to EMS structure, performance, and equity. delays related to, as well as delays, unclear governance, like who's really making all of the decisions around here? You know, who do we hold accountable? Where do we go for leadership? And then calls for reforms to prioritize residents over competition and profit. And you saw that in the quote that we began with. So we asked them, of course, this was just an expansion of the survey, what are the drivers? And you can see we've got some quotes here related to aging population. Some folks were reporting getting calls when someone was lonely, right? And that's not uncommon, we see that, right? Also related to mental health and substance use disorder. We're seeing EMS step in where other systems have failed, where housing has failed, behavioral health has failed, and transportation has failed, as well as access to care. This is going to come up particularly as we look at considerations with the federal government reductions in federal funds. And then also there were some concerns about contracting and regional models. So many of the municipalities who reached out for, or who were even exploring contracts, said we needed to do something. We needed a stopgap to take care of our residents, and they responded to that by getting a contract. They also were equipping their fire and police to be medical first responders when able. And they also were talking about possibilities of a regional or a shared EMS model. They saw the benefit to a contract is getting faster local service, more resident protection, and more accountability. But they saw risks as increasing fragmentation across the county and inequity, as well as legal concerns. So someone said, I don't like that residents in one city get better response just because they have a contract. Then when we also, in our analysis, we saw concerns about fractured coordination. So calls for a county EMS director with teeth to actually fix this situation. They wanted more transparency and accountability. Transparency in data came up, as well as transparency in protocols and just the underpinnings or the workings of EMS. And then distrust of private EMS providers. So concerns about EMS agencies putting profit over people. And in our interviews, they came up with some recommendations. They won't be a surprise because they're mimicked in the survey. So stronger system-wide coordination, improved transparency, not only about data, but also about contracts and those protocols, those guides for how treatment is provided, more education, you would think, for the public. And that's included in this, but also for municipal leaders. Our elected officials were calling for more information, but not information just for information's sake, but information in a way that's usable, that's actionable, that you don't have to work so hard to find out where it is. It's at your fingertips so that you can share that with the folks that you serve. And then expanding alternative response options. So looking at behavioral health research or resources to address non-emergent needs that folks are calling 911 for. We also did interviews with the agencies. They called out fragmented systems, loosely coordinated, a lack of a countywide perspective that was leading to gaps in coverage, confusion amongst themselves, so confusion again amongst those EMS agencies, and uneven distribution of resources, particularly between Flint and the outlying townships. So one person said, you'll see 5 ambulances sitting in X city, but none in these other cities. They also noted some operational barriers. So scope of practice, vulnerability, or variability. So Genesee County is seen as more restrictive in what the EMTs, the paramedics, those folks can provide versus other neighboring communities. This is related to providing albuterol as a treatment option, and then some other areas that folks were saying, we just want to provide this service. We're able to do it in other communities. Why can't we do that in Genesee County? They also talked about staffing shortages, dispatch concerns, lots of issues related to that tier 2, only the 2 tiers that are being used in Genesee County. And some agencies are being dispatched long distances to cover gaps that were elsewhere. And here's what they called for. Centralized oversight. We're hearing this over and over. Contract clarity. Inconsistent contracts make system performance hard to track. Protocol consistency. And transparency in data and sharing. So the EMS agencies want better access to data. They want better access to the performance metrics. So, and the quote here is, "It's like every agency is just out doing their own thing without anyone looking at the bigger picture." And that's what this evaluation, that's what this structure that we're talking about can provide, can equip us all to look at. We also did an interview with the 911 consortium. 911 handles roughly 500,000 calls annually. That's about one call every 75 seconds. Some challenges that they are facing is this outdated CAD system, which is in the process of being updated. They also face challenges related to ambulance availability, especially in non-contracted areas. So private EMS is only required to have one unit available at all times. And IFTs, inter-facility transports, can reduce the availability for 911 calls. So that's when someone is being taken to dialysis, and that can take resources away. There's also a challenge related to misinformation and unrealistic public expectations about what 911 does and what they don't do, and limited public education, and this is largely due to a lack of staff or resources on 911. That they're busy providing the services and so are unable to go out and do the community outreach. There's also an overall system strain. So disparities in response time between contracted and non-contracted areas was their perspective. There's also a transfer prioritization by agencies that can reduce 911 availability. And this continued focus on response times is overemphasized at times, and it distracts from the other things that might be causing delays, like offload delays. So when the EMS unit gets to the hospital and they sit with a patient because the nurses or staff at the hospital are unable to take over the care of that patient, and the EMS rig is trapped there or is unable to move on. And the recommendations here, so these are all already in process. This CAD upgrade, this is that dispatch and tier process, ongoing community engagement, and then interagency collaboration through stakeholder meetings are all things that have been ongoing and continue to be ongoing. We doing all right here? So far, so good. All right, all right. We also reached out to MedControl and asked them for their perspectives. They noted that they have an oversight role with limited authority, that they're a statutory body overseeing EMS protocols and provider credentialing, but that they can't direct EMS operations or even resource allocations, that the protocols have the force of the law, but enforcement capacity is constrained. We also see related to resource and staffing, that there's a lack of capacity to provide the public education or do strategic planning or countywide evaluation, and that they're reliant on hospitals in the county for funding, and they don't have a dedicated revenue stream. They also noted system fragmentation and political tension associated with the contracts. And although they see the contracts as positive for accountability, it does cause challenges across the county, and we've talked about that. They noted training, communication, and public awareness gaps. Again, education is through MedControl, education delivery relies on the EMS agencies, which could be resistant due to cost. Public and elected officials often misunderstand system structure and MedControl's role. We saw that. We saw that in the responses to the survey and the interview. And that MedControl has limited visibility into real-time EMS operations or community-level trends. You know what this is talking about? Access to data. And access to data in as real time as possible. So real time meaning as quickly as the data is made available. These opportunities are not in process. These are future things that could be done to expand provider training and direct communication, to lead protocol innovation. So look at alternate destinations for where folks could go beyond the hospital, and then strengthen quality improvement and system accountability. So what we saw from 911 were opportunities already in progress. What we're seeing from MedControl are opportunities that we could do in the future.
I was just jotting down some additional notes on this piece. So we have a colleague who's not here. He's a faculty member in criminal justice at Michigan State and a statistician by training, so I will do my level best to share what he did. So There's a couple of ways to study the differences either between census tracts or communities or like municipalities or contract status or not. We can do simple correlations. So like, you know, what's the average value of like the response time in a community that has a contract? What's the average response time, or we were using fractal response times, which I'll get to that in a second. Like say, so comparing communities that have contracts versus communities that aren't. But what he did was specifically looked over time, how did response times change in different types of communities? So again, whether you're contracted or not. And this particular process called interrupted time series analysis is looking for a gap, a particular thing that's happening. So in a lot of analysis, you would take the entire sample and you would look for some association. But we know that things happened during the last 7 years or so that we had our data for. One of those things was COVID onset. The other was that communities started more actively contracting with independent services. And so we both ran this, Wally ran this analysis where month for month he's looking at the percentage of calls that are meeting this fractal response requirement. So for urbanized areas, that's 8 minutes and 59 seconds. For rural areas, it's 12 minutes and 59 seconds. And so we're looking at the proportion of calls that were falling inside that threshold, because it's not just like, ooh, did you make it there in like 3 minutes? Like 3 minutes and 47 seconds is good too. So in this world, the thresholds are at those two different time points. And so what he did was looked at and compared jurisdictions with contracts and jurisdictions without for this. Do we have COVID slides? I'm blanking. Yeah, okay. So we're not gonna worry about that. Basically, the gist of the findings there was that EMS did struggle in the immediate onset of COVID, as we would expect. That's not a huge story, and it's not as germane to what we're talking about. So yeah, so we're gonna focus on the contracts. And importantly, so zooming super close in when communities started contracting independent contracts, the non-contracted communities saw a bump downward in the percentage of calls that were falling inside that threshold. But ultimately, it wasn't a significant difference in how, what percentage of these calls were being responded to, because we saw a little bit of a drop-off overall in calls meeting the threshold, both in the treatment and control groups. And one thing we're thinking, so I'm not just reading off of this, one thing we're thinking might be a cause behind this is that, Alan, our GIS analyst, made a series of hotspot maps where we looked at where is there significant spatial clustering for every individual ambulance company and the Flint Fire Department. And so as you would expect, contracted communities, especially as they onset. So we did this for every year, and over time, those contracted communities really entrenched hotspots for the service providers in their boundaries. So what we're thinking is that the other companies that didn't have contracts with individual communities shifted more of their service to other communities. So it's just kind of a resorting of the different companies in space. Dashboard?
Okay, yeah, so I'm just gonna demo this dashboard that we've been talking about. Is it this one?
Nope.
Nope, that one?
Don't show that one yet. Yeah,
Okay.
please.
This is a dashboard that we wanted to just take the current landscape of EMS from the state data that we received, so 2019 to 2024, and put it in the hands of whoever's viewing it instead of cutting up the data into complicated, graphs. You can just do it yourself. So if you're interested in the city of Burton in 2019 for Patriot, you can, or a series of agencies, this pie chart gives you kind of what's the sort of percentage of calls taken up by each agency. And another aspect of it is those hotspot maps, which it looks like it's having a slow time loading. Let me try this one more time. Yeah, yeah. Okay, some sort of web thing. Okay. Anyways, there are hotspot maps here, which we will share. And we've already gotten feedback about like sort of what we want to see. They're broken down by year, so you can sort of see that linear progression through time where the contract hotspots started to cluster. Yeah, it may be something to do with the Wi-Fi that this is on, but, and then tier 1 or tier 2 status, if you want to look at specific status. In tier 1 being emergency, right? So this puts, instead of breaking down and giving just a bunch of complicated graphs, whoever's using it can sort of figure out what they want to see first. And we'll share that with everyone too.
And again, so the dashboard, link to the dashboard has not been shared publicly. We wanted to, this is the framework of all of the data that we have from my MSIS, that state repository. And what we want to do is build out a dashboard that is available and usable by the folks, by the end user, by you all, right? And accessible by the community, but that's a decision that the commissioners will need to make as far as what's publicly available and what does it look like. So in other words, like I said, how do we make this more usable for folks to access the data? And this is what the some of the maps would have looked like. I apologize that that's not pulling up on my laptop. I have clearly worn out my laptop today, so. So now we're going to move into some recommendations and action steps. But before we do that, we want to acknowledge all of the folks, the first responders, the municipal leaders who are doing such amazing work in the community. And what we don't want is to build something that provides more work for them. But this is a shared responsibility. We all live, work, go to church, and play in this community, and it is our opportunity to make sure that the people of Genesee County and Flint and surrounding areas are taken care of. And so that's, we do this together. So what I'm saying is that we're in this for the long haul. So our stakeholders said they want 6 things: improved system coordination and oversight. They want better access to data and data that they can use to support transparency so that everyone can understand it, no matter if you're a fire chief or if you have no exposure or familiarity with EMS, that it's meaningful to everyone who can benefit or make decisions based on the data. They also want expanded community outreach and education. This is getting us to this EMS misuse and understanding of the elements that go into effective EMS beyond response times. So making sure that the community has a good expectations. They also want standardized protocols and standardized scope of practice, so the services that EMS professionals can provide. And then strengthen cross-sector coordination for high-need populations, for our aging population, our folks who are struggling with substance use disorder. Let's make sure that we're bringing folks together, that we're bringing agencies together and interested parties so that we can address this collectively, and that EMS is not off on its own dealing with just dispatch calls, but that we're integrating it into the larger system, and that we're also paying attention to those upstream drivers, what causes someone to pick up the phone and call 911. So these are the things that our stakeholders said that they have prioritized. So we took this in mind, and our proposal is the creation of a Genesee County EMS collaborative. You can call it whatever you want, but it's an oversight group that is a centralized leadership body that would then advance all 6 priorities. It could be just an ad hoc committee, it could be something, but in some opportunity to get countywide representation from Med Control 911, but also GHS. The Health Coalition has already said that they're interested. MSU is interested for sure. And we can invite Hurley and others to the table to address those 6 areas, because the functions of this group would be to support data access and transparency through the dashboard. And then you see here, it's a health equity report card, which I'll show you in just a minute. But to promote bi-directional communication, because what we saw in the surveys and the interviews is that very often folks perceived some of the entities as just being unidirectional, so just providing information out and not necessarily providing the opportunity, even if it exists, it wasn't perceived as existing by some elected officials and agencies. So there might be mechanisms for them to provide input, but it just wasn't in a meaningful way, or they didn't feel comfortable providing the information in that manner. Also, the group can coordinate across high-need sectors. So invite VAAA to the table to address the needs of aging population, or the senior centers or others, and then guide community engagement and education with an overall goal to move from fragmented fixes, like contracts, which some folks had to reach out to a contract to take care of their residents, to really coordinated system reform that supports everyone in the community. Oh, we also created some resources to help us along the way and get us started. So this is a when to call 911 resource that could be used by any municipality. You can attach a Davison Cardinal or a Grand Blanc Bobcat, or a Flushing Raider to it, or some way make it hyper local so that the communities can get a better understanding of when should I call 911 and what are alternatives. And this is in Canva. It can be shared with anyone who's interested in it. We also created this EMS Health Equity Report Card. What we wanted to do was make the information that we're talking about today more accessible and more portable so that folks can actually act on it. So I'll walk you through a little bit of the document. Again, this has not been made publicly accessible. We want all of your input in what should be included and formatting, but nonetheless, it is a resource to take the story of EMS into other areas so that it's not, just the folks from 911 or med control telling the story, but that it's all of us. So next steps, some things that we should keep in mind as we continue this discussion of what this can look like for Flint and Genesee County. There have been some changes, and we talked about it. So 911 is undergoing an upgrade, which is still in process. They're also moving and going through the move process. You're all familiar with that as well. GHS has opened their Behavioral Urgent Care Center, which can take care of some of the burden potentially related to mental health, folks who are suffering with mental health issues. But we also need to think about some external considerations with federal budget cuts, both ones that have happened already and ones that might be happening in the future. Rising health insurance costs, again, these drivers of EMS usage, as well as the Medicaid expansion renewal, so Section 1115 waiver that will be expiring next year. And then let's think about some opportunities that we can do together. So continued partnership and support, leveraging student projects. I can't tell you how many Masters of Public Health and med students that I have that are interested in looking at, and we already have one that's doing a comparison of protocols. For OB protocols in Genesee County, she's doing a comparison between Genesee County and Saginaw. This has already started. There's interest and support for it already. It's just a matter of coordinating it and getting it to go in the direction that we all think that it should go in. And then community education opportunities. So we're starting a group that will look at turning Flint and Genesee County into a heart-safe community. Detroit is already there. We want to get there as well. This is mapping out where AEDs are, as well as getting community CPR training and doing a whole lot of stuff that we can do together to support the health of our community. And then, of course, I'm a researcher. I had to put in joint grant applications because we want to do that together in order to address the needs. I'm bringing us back to this process map. This is our second to last slide. This is where we started, right? So this is the element or the components of EMS that we're looking at. But we also outlined opportunities for change. So we took that same map and we said, so what are some evidence-based interventions, initiatives that are going on nationwide that we could explore for future opportunities? And we mapped that onto this process map. So you can see in the center, we've got things about how do you address the structural solutions, and then we've also outlined some areas that are listed for each step. And that's the end of our presentation. We'll open it to questions or thoughts.
All right. Well, first and foremost, thank you so much, the entire group and team, for your presence here today, the presentation, so much information, and we're excited to have you here to share it and to be able to ask questions and discuss. With that said, who wants to discuss, ask questions first?
Thank you, again, for the really rich research study. I heard you say that there were 36, I heard you say there were 36 elected officials that were respondents, but I wasn't quite sure of the other respondents to the study. Can you clarify that?
Yeah, so a survey was sent out through internal mechanisms here at the health department. I'm not quite certain who actually received it, and the respondents, some folks declined to say where they were from or who they were. So, you know, it was the township supervisors, mayors, not so much the police chiefs. I think that there were a couple and potential fire chiefs that responded, but we actually got a larger number of responses, but some folks declined to provide any data. So it was upwards of, I think, 50, but there were 36 roughly that were had contact.
Okay. And I wondered if you could talk a little bit more about the fragmented coordination, and that was one of the big recommendations, that we have better coordination. Can you give an example of how another county, what it looks like to have centralized coordination?
Yeah, sure. Do you want to talk about where you?
I'll make an attempt. So you look anywhere, I'm using broad terms, you can fact check me, but you look anywhere else, if you call 911, you know who's going to respond to your house. You look to the south of us as an example. Livingston County has a county EMS system with support from the local municipal fire service. So you call 911, fire service might come out and start first response type treatment and assessments, and eventually their ambulance service, the county ambulance service, will come to also take care of you, provide interventions, and then eventually transport you to definitive care to an emergency department. You look to the north of us. It's not a county EMS system per se, but it is largely a single ambulance provider that they use, which is MMR, which also operates down here. Prior to the larger EMS contracting discussion in most of the county, if you called 911, it was very much somewhat random as to who would answer that call. In the city of Flint, for example, prior to all these ideas, or they still don't have, there's still not an EMS contract in Flint, but they have the fire service answering some of those EMS calls now. But prior to all that, it was very random. So there would be delays, potential delays in taking care of a patient, and this idea of lack of accountability. You're not sure who is supposed to be responding to the call, and who's ultimately responsible for ensuring that someone does show up. Yeah.
So, I heard you talk about the two-tier system that we're transitioning to. Can you give, we're transitioning away from it.
Away from, yeah. So our current dispatch system, and certainly Commissioner Flowey, you can bail me out if you'd like. Two-tier system, so based on so if you call 911, they're gonna ask you some questions like, what do you need help with? And based on the type of medical complaint you have and some of the questions that are asked of the caller determines the prioritization of the call. So a tier 1 type call is the highest acuity type of patient, and so you're typically going to get an ambulance with lights and sirens and all of that, whereas tier 2 you won't.
So what are we moving to?
Moving to a more granular system, in my opinion, better in terms of caller interrogation to really drive down and determine what is the need of the individual, and are we able to better match the resource to the need?
Okay.
Whereas kind of it's just two, like either you go lights and sirens and you send everything, or you don't. Whereas with this new system, it's more refined, and in most other communities that have this other system we're going to, are better able to have a better match between the needs and what is actually provided.
Okay. And one more question before I shut up. It's been it's been a long time since we've initially contracted this study. Can someone remind me of the situation that triggered this study in the first place?
Oh, that's a good. I thought you were asking about the data.
You wanna handle this bad boy?
Part of it was community.
Yeah.
Good question. From my memory, I think you were getting a number of folks coming to meetings and having some discussions, and there was kind of an unclear kind of, the residents were coming with information, coming with concerns, but there was unclear about whether those concerns were more based on fear or based on information, data, and there was an interest in kind of getting to the bottom of the system, kind of having a landscape analysis with some recommendations about how to go forward to make sure that the entire county is getting good coverage with all forms of 911, right? I think that was, from my memory, that was kind of how it was reached out to us, and then put together, and then has been studying it over a year now. I think that's my memory of it, something to that effect. Pretty close, right?
Okay, thank you.
Yep.
Thank you, Commissioner Kuzino.
Yeah, maybe I can put a little clarification on that, because back in 2022, I was approached by many people about problems with the EMS systems. So I started pushing behind the scenes to find somebody that could study it for us. And due to timing and a lot of other things, that took a year of behind the scenes on my part to find this group and them to put it together. And then at that point in time, after about a year, then we contracted with this group. And then they did their thing over the next year and a half. Just to give you a little background of how I did things, is I stayed out of it. You know, once we got their contract, I didn't want to influence anything, so their surveys, I never answered them. Because I didn't want me to I wanted to know what the community wanted and what the community expected. And somewhere in that process, you know, I had been going to some of the EMS meetings and just sitting up in the audience, and I could see that there was issues. But somewhere along the line, when Commissioner Avery was chair, he appointed me to be one of the official reps on EMS. And then that's what I started getting more and more involved with it, and I started seeing more and more things. And I think maybe we had already contracted this group at this point in time. But when I first started looking into it, it was like a big onion, you know. I would peel this back, and it just showed more. And I'm not an expert. I mean, I may know a couple of things, maybe three, but I'm not an expert in what these people have studied for us and coming back with recommendations. And then once I got onto the EMS board, I saw a lot of things, a lot of infighting over these contracts and et cetera. There's a very hardened views. The system is running basically trying to run two systems to keep two different groups of people, half the county happy and the other half happy. And there's no way to run a system. The big emphasis, like they've said, was response time. And that's not the only factor that needs to be looked at. So when I realized they were looking at a bigger picture, I was very happy with that. And because that's not the only issue. One of the things that I have noticed is that the way the consortium is set up at this point in time, I have a personal issue with it, and I'll express it at this point in time. But you have a lot of very good people. It's all the different municipalities that sit on this. And then I think the fire department and the chief and the police, do they have a vote on that?
No, but they have the advisory board.
Okay.
That's where they,
All right.
that's where they come in.
I wasn't sure of
Yeah.
that. Okay. But at any rate, and then, of course, then Brian was elected here, and he got put on that too. But these are all elected officials from all our communities. They're very good people. They're not experts in running how the EMS system works. And I don't feel, this is my personal feelings, I don't feel that they have proper oversight of what the staff is doing, because they're not involved as much as they don't have the time. I'm not trying to say anything bad about any of these individuals, but they don't have the time and they don't have the expertise to oversee it. They hire a staff to oversee it. I see a lot of, I don't know if it's directed towards me because I've been a little outspoken, and everybody on this board knows I can be that. I don't have a problem with it, but there's obviously decisions being made behind the scenes, and then I feel that all the different people that sit on the consortium, whether it's Vienna Township or Fenton Township or whoever, they're rubber stamping things. And it's not because they're bad people or anything, it's just they're dependent on some people to make those decisions. But I don't feel, and Brian may feel completely different than me, but I don't feel that there's real, true transparency. I don't know if I want to spend the time talking about the recent increase in the surcharge that we just did. We're here, and I've been waiting for 2.5 years to get to this point. But, when I first got onto the EMS board, the 911 consortium, they were talking about going, and they needed more money. And so they wanted to do the surcharge up to the max to $3. And I asked for some documentation on the finances. And what I was provided made absolutely 0 sense. So I brought in our finance department to look it over and to talk with them to get that squared up. They were talking about building a whole brand-new building. Mm-hmm. And I showed them where they could not afford to do that, even with going to $3, which was the max. I heard some very derogatory remarks towards me because I made them spend some money on further accounting. But I knew that we put that on, if we put that on there, and that the public, they're generous, they would vote for it. It's a emergency service. I knew it would pass, and it did. Let me backtrack just a little bit. Some of that change that they wanted to do in building that new, they already have a building that they own, free and clear. All they have to do is provide maintenance on it, but they lease out half of it, or used to before they moved, leased out half of it to the state police. And I made the suggestion, well, the state of Michigan's got far more money than we do. Why don't you ask the state police to go get a new building, and you guys just take over, you need more space, take over the building. They refused to do that. The tax increase, or the surcharge increased, and within a week or two of that passing, all of a sudden they come out with this plan that's ready to go to move over to the Health Plus building. That was never mentioned in any of the talks with me leading up to that point about that's what they wanted to do. So they obviously had a plan before they went to the taxpayers to ask for that increase. And so, at any rate, I was the one lone person that voted no to do that, for that contract. And I think the only reason I was the only lone one is because they asked me last to vote, and I think some other people would have voted no if they would have voted. But anyways, I was called last. Then we get over there to the Health Plus building, and we haven't even moved in yet, and then they're talking about buying the whole doggone building. And so a lot of things happened, and of course I was opposed to that. I never said anything, I just let the process work. And they finally came to the conclusion they couldn't afford to do that. I knew they couldn't afford it. So that, it just, I don't know, last week or 2 weeks ago, whenever the last meeting was, they voted not to do that. So that's what I'm talking about. The system is not transparent. And that, I feel, is intentional. That's my personal feelings, having just sat on it for a little while. So I've been waiting for this to come out. We have to make, I think that what they're telling us is that we have to make some big decisions moving forward. We have to solve some problems. And I think that we need to, and we have the power. A lot of people didn't understand that when I got there. But this 911 is something that we created at the county level by state law, if I remember right. And that's how we set it up back many years ago with all the different municipalities sitting on that, and this board having 2 spots. But I think, and that was fine for back then, but I think things have changed enough now that we need to restruct the 911 consortium and get more professional and expert people on that board. They would still have to hire a staff and run it and all that, but to have a more professional consortium or board, if you will, and I think that's the first step that we need to do. I mean, I'll follow their recommendations. You know, they are the experts, and I listen to them, and I appreciate everything you guys have done. But I personally want to follow what they're doing. Now, in the past, this board has done a study many years ago before I was on the board, similar to this. I don't know what the process was, and then they come forward to it, and then they never followed the suggestions. I personally, I want to follow it, but I'm one person and there's 9 of us here. And so, you know, we vote, we make decisions, we discuss things, we debate them. Sometimes it gets a little heated and I'm to fault for some of that. And I think we need to, I don't care one way or the other on this contract, non-contract type thing. But the county can't keep, in my opinion, operating on 2 systems. You gotta do one or the other. And there's been a lot of bickering in the past with various people as to whether it's lawful or not lawful or whatever, but, you know, who knows? But we need to make some decisions, and how I look at this is it's a, you know, I've always been involved with the budget and da-da-da-da-da. I mean, that's been my thing. But this is life and death. You know, these are the most important decisions that we need to make. You know, to stay financially solvent, hey, that's great and everything, but we're talking about our people from one end of the county to the next. And everybody should be treated equal, and everybody should have the same opportunities when it comes to the EMS system. And I don't feel that's anywhere close to that at this point in time. Now, that's my personal opinion, and other people will have others, and that's fine. But I think we need to move forward after maybe a little more discussion with them, with making some changes. Other than that, I don't have much to say unless I.
Can I ask one follow-up question? So they're in the old Health Plus building. Are they taking up all of the floors or just a couple of floors?
The top floor.
Just the top
And a little
floor.
bit down on the first floor.
Okay. So why couldn't the medical control folks and the EMS agencies all be in that one building? Would that provide some coordination?
Well, there's still 3 floors that are
Vacant.
unrented.
Yeah.
I mean, the building is basically empty other than us being in there.
Yeah, I was just thinking out loud about how we might, I mean, if we have the power to do that, and if we created all, I don't know, did we create all 3 of these authorities? And if we created them, can we direct them to be under one roof?
What all 3 authorities? I know you were
Well,
talking about
the medical
911.
control authority,
I don't know, that's state law once again. You know, and we contribute some of the money to running that, and I know our paramedic, the sheriff is on that.
okay.
In their explanation, they said the county commissioners were on it too, but I don't know how, because I don't know of anybody from our board that's ever sat on it. But it's basically the 3 hospitals and the sheriff.
Okay.
And I have followed up with the sheriff's department. I have checked to make sure that they're attending, and they are, which pleases me. But I don't know who the third entity you're talking
But
about, Doctor.
EMS, I think I saw EMS agencies on there.
So those are the.
Oh, yeah, okay, the actual ambulances.
Yeah.
I don't know how involved they are in that decision-making, other than they are going out and contracting, you know, with the various communities. They briefly, and I'll add this, but they briefly talked about that when they started, different municipalities started the contract, and the other municipalities nearby saw a diminished. I saw that firsthand up there in my end of the county recently, about 6-8 months ago. Vienna Township, which is in my district, they decided to do a contract, and theirs is a little bit different than the other ones. Immediately in Thedford Township, which is where I live, people started coming forward about not getting service for 40 minutes. And it wasn't just 1 or 2 times, and they're claiming that people died and et cetera. I never followed up with that. That individual, and I think you was there, they came and they spoke that time. But I immediately saw how those contracts affect the other communities, and that's not what this board is about. This board is about making sure everybody is treated the same. And so, the consortium at one point in time served its purpose, but I think it needs to change, and that's what I personally would like to see, but that's gonna require open discussion.
All right, thank you, Commissioner Flewelly.
All right. Thank you, Mr. Chair. Thank you guys for the study. I've got a lot of notes. I promise not to cover them all.
We're here for it.
But if I may, so I'm really glad that you guys did include talking about the Public Health Code or the EMS Act, 911 Act, and Policy E, because those are really important pieces, I think, that fit into the overall structure of the system itself. I have firsthand experience of 20-plus years of the Wild West, and like you indicated, Dr. Reese, you didn't know who you were going to get. It was cutthroat. You did see stacking of ambulances at different places. And when we talk about response times, I know that's not the penultimate metric for system viability. However, if we're talking difference between 9 minutes and 11 minutes, no, probably not. But when the out-county for several years, Vienna, Thetford, Fenton, Argentine, Richfield, Davidson, Forest, experienced 20, 30, 40-minute wait times, that's when you get into response time really does matter, right? That's something that has, for the most part, changed. There are still those pockets that can experience that. But I'm glad you mentioned Policy E, because that's an important piece to me, because that really breaks down that language in the Enabling Act of closest, most appropriate. It also explains that language is originally intended for police, not fire and EMS. And so that clarity of the difference there, I often have used the fire department example. It might be a fire department closer, but it's in a different municipality and jurisdiction, so they don't get that call, right? So I think that's a very important piece when it comes to the overall conversation of we're always going to talk about contract versus non-contract, right? Also, I think engaging with the EMS agencies in the, what did you call it, the collaborative, EMS collaborative? I think that's very important too, to get an understanding of why it looks like it does, right? So currently we have half the county's population under contract. Should the non-contracted areas not have received better service since May of 2022? Because now you have those three companies that really don't have to respond to half the county. So what happened there? There's a disparity there that I think we should probably look for answers to. If I may continue. So one of the things that I think is really important, we've talked about this before, is that education piece. And so as you look through the presentation and you see the responses from these elected officials, it's disheartening to me that while they share negative opinions of 911, med control, the EMS system as a whole, contracts, what have you, they also, there's a high indication of the fact that they don't know anything about the system, or they know very little about the system. They're uneducated to a point of the ins and outs of it. And to me, as an elected official, as a public official, I feel it's incumbent upon us to educate ourselves. And I find it really concerning that so many would share an opinion of something they're uneducated on, and really focus on what they perceive as the negatives based on either personal experience or what they've been told, right? So I think that piece is really important. And to expound a little bit on what Dr. Reese was saying, just for the board, so the Tier 1 versus Tier 2 in the new EMD system, the way that breaks down right now currently is a Tier 1 medical would be more life-threatening, whereas a Tier 2 would be broken leg, sprained ankle, something that's not immediately life-threatening. And in your study, so a part of the problem that we have in this county right now, currently, We send an ambulance for every call, every single call. Doesn't matter. It could be anything from an 85-year-old with chest pain to a teenager that twisted their ankle on a football field. They all get an ambulance. And so where the new MPDS EMD system comes in, it goes from tier 1 versus tier 2 to a 5-tier system, Echo through Alpha. So Echo and Delta would be your heart attacks, your full arrest, your immediate, they're gonna die, you don't get there right now. Down to Alpha, which could be, can you take an aspirin, can you call your doctor, can you get there later? So those Bravo and Alpha calls might not get an ambulance, and I think that would go a long way to freeing things up. As far as the med control board, their makeup, yes, it's the hospitals, sheriff's department, 911, but there's also every EMS agency sits on it, and a first responder agency. So you do have a pretty broad-based opinions. Now, can that be expanded? Absolutely. Absolutely, you can do more with that. What did you, when you address the wide disparity of the difference between contracted versus non-contracted, do you have any opinions, any recommendations how, maybe you didn't put it in your presentation, thoughts on how that could be solved? Do you feel that these contracted areas, which I've never made any bones about, I'm supportive of, do you feel that that's something that has really been beneficial to these communities that have done it?
That's a good question. From asking the stakeholders, not looking at the data, but just the perceptions overwhelmingly of that survey that we did and then those follow-up interviews, the folks who had a contract were more satisfied. The folks who didn't have a contract did a couple things, said that they weren't satisfied with the services that were being provided, and in some cases pointed to the contracts as being the influence for why they were receiving a reduction in service. As far as looking at, you know, what folks are seeing in the emergency or from the data perspective, if you want to add to that, go ahead.
Yeah, so we were limited in some of the outcomes we could evaluate based on, so for example, in the county data, we had details of specifically what RIG responded and what they did and what, like every single step that they charted out. But the problem was that that was about 100 lines on average inside of all of those hundreds of thousands of records. So there was no way without some kind of AI tool, which we lack the expertise to use effectively, no way to sort through that and see, like, for example, you know, were people getting better care? Were people, you know, having shorter stays in the hospital? Also, we didn't have that outcome data. Like, once people reached the hospital,
right,
we didn't know if, you know, for example, the fact that, you know, a contracted service provider responded to them, like helped them get there more effectively or something like that. So we were only able to show, for example, what those fractal response times were, like what percentage of cases were being responded to within certain amounts of time.
Sure.
And there were those other factors that I mentioned. For example, again, we weren't focusing a lot on COVID in this talk because it's kind of a long gone sort of situation, but thinking of something, you know, a future public health issue or a future massive budget issue or something else that causes disruption in service, we could go back to that and use that as an example, because we did see across the board disruptions with COVID, for example, in terms of the level of service. And so it was interesting. And again, going back to what I had shared, it's possible that because there are other service providers, even though those other communities didn't have exclusive contracts with those providers, that, you know, if you know that, for example, this township has a service provider, you as another company, you're not going to hang out there as much. You're going to stay back in the next township over and focus on, you know, this handful over here that don't have those. So it might be that the fact that we didn't see huge jumps in fractal response time, like persist over time, could be because of that. People kind of, the other service providers adjusted.
And when did your response time data end? From what year to what year?
24?
Okay.
2024, yeah.
So you're about 2 years into the contract.
Yeah, we had a couple of good years of data for that, yeah.
Okay. Can can I continue? So, one other thing that I know you touched on a little bit, when you talk about outcomes, is there a recommendation going forward to look more at community paramedicine, mobile integrated healthcare, which, from my experience in other parts of the country and state, is a higher level of licensure doctor, nurse in a 911 center that can help to screen these calls and determine whether or not an ambulance is needed, determine what level of care is needed, and it has a really big impact in some places on freeing up resources.
Yes, because what this is providing us with is, to answer your question, absolutely. We want to be in a position to take on and integrate these innovations that are working in other communities in our community, but in order to do that, we need to understand the system, and we all need to understand the system, right? And so this is how we begin. When we were talking through the data, you heard that there were over 1 million, so picture an Excel file, right, Excel? And there were nearly 900 and some odd different rows of data. So there are a lot of questions that we can answer with this data, but it's our opportunity together to figure out what those questions are. What are the answers that we need in order to move forward to address the needs in the community, to address the structure that's driving some of these disparities or the differences that we see, so that then we can take on those innovations that we all are eyeballing as potential. I mean, Genesee County is an innovative community. We do lots of amazing stuff here, and we can do that together, but we just need the structure to help us make those good decisions for the folks that we serve.
Okay. If I may. So, thank you. You also touched on neighboring counties and the systems that they have. So you have Livingston County that has county EMS. You have Lapeer County that has kind of a quasi-county EMS, and then Saginaw County that has a single provider contracted with MMR. As you looked at that and compared that with Genesee County, one of the biggest challenges that has been faced over the years is how do you present a model like that for Genesee County? Because geographically, demographically, population-wise, Genesee County is different than all three of those counties. And is there anything that you saw in your research and your data that may suggest that, aside from a massive millage, that there's something that could be done countywide? Because I'm here to tell you, the old system from 2020 doesn't work. It absolutely does not. And there's opinions that the contracting model doesn't work for everyone. Flint, City of Flint, presents a huge challenge. They average 75 Tier 1 calls per day. You need a massive amount of ambulances to properly handle all those calls. So that's a challenge I think we face as a border as a community, is how do you come up with a community solution when we're different than almost every other county in the state, right? You can't look at Wayne County.
Yeah.
It's all urban.
Yeah.
Genesee County has the City of Flint, but we also have Argentine and Gaines. So how do you properly serve all those people to ensure that, granted, somebody in the City of Flint should not wait 30 minutes for an ambulance. But you know what? Somebody in Montrose shouldn't either. And so how do you, and maybe you don't have an opinion, maybe you don't see anything right now that works, but how could you build an equitable system that provides the same level of care for a Davison Township versus an Argentine Township?
That's an excellent question, and if someone else wants to come in and add to it, we requested data from similar communities when we reached out to the state for that data. So we asked for Pontiac, Saginaw, and I think Livingston County. It took a very long time, and it took some high-level phone calls in order for us to get the data that we did get that was only for Genesee County. So we can't do an even apples to pears comparison because we don't have that data. But what this provides us with is the opportunity to then answer those questions, to look at, what are other communities doing, and, even anecdotally to ask around from our colleagues and our partners in those communities, what's working for you, what's not working for you. So it doesn't have to necessarily be a full-on launched study. It can be something more informal, just to look at what the structure is being provided. We did, just to, again, remind folks, we did ask for that data. It was like pulling teeth to get data from the state to get what we did.
Oh, I know, I've tried to.
Were you a part of that phone call?
Yeah,
We had to get a, Jim
I've-
had to be- Jim had to make a phone call, and literally like 2 days later, or not 2 days later, but
I've spent 6 years trying to get things from the state of Michigan, so I understand completely. So
yeah.
I guess the last two things, if I may, that I'll say is, again, and I've mentioned this before, I think that education piece might be one of the biggest hurdles to overcome, to get it out to the community, obviously the elected officials too. And the providers may have a big role to play in that. I mean, obviously they bill every time they pick somebody up, right? But, actually, two more things. In your study, did you encounter, so Dr. Reese may have experience with this, but, so EMS is not considered an essential service by the state of Michigan, like police and fire. Do you find that that's a hurdle to better reimbursements from health insurance, Medicare, Medicaid, because it's not considered that essential service? Because the last increase they did was pennies.
I can try to answer that. So I thought about this a lot. I'm not sure that simply designating it an essential service on its own would change anything. It would need to be thought of, so back up. EMS is not an essential service. Do people know that? Like that's bizarre, right?
Yeah.
But just designating it an essential service may not make a difference. There also needs to be some discussion about how is it funded, right? How is EMS funded? And are we doing the right thing for the population? To try to answer your question about what have I thought, or what is my opinion about the county, I don't know that a one-size-fits-all approach is best, to your point, because we are so different compared to our surrounding communities. But I think the communities, at least that I've been to, that I think do the best is that public-private partnership, because you can leverage the expertise of the public service with the support from private EMS. Once again, that's probably more of an offline discussion, but there are ways to look at the needs of the county, whether it be like a system status management type program, to look at predictive model based on time of day of the week, and so on and so weather. You can predict where calls will take place and better allocate resources, but because we are operating in a siloed, fractured system, it's difficult to do that.
Sure. And I can tell you, the communities that I represent that have the contracts, it's a night and day difference on accountability. They have a direct line to someone that they can call and address any issues. They get quarterly reports on response times, patient outcomes, performance evaluations, and everything else, whereas before, the process was you have a problem, you send a letter to med control, and they do their thing, and you get a letter back saying that it's been resolved. So you don't know, right? So I just thought that was, and that's kind of what I was getting at, is we focus on police, fire funding, but that EMS piece is always left behind because it's all reimbursements, right? All the contracts in the county that I know of are no cost, so they make their money by charging insurance companies, charging patients. And when the state allowed reimbursement level is so low, you know, they've got 20% collection sometimes on their billing, and it's not a viable way to go. So, thank you. Last two things I'll say is, when it comes to the education part, when it comes to the misuse of resources, I have one example that has always stuck in my head from a few years ago. So some of my friends on Flint Fire were dispatched to the bus stop outside Hurley Hospital because a patient wanted to go to McLaren and they wouldn't transfer him. So he walked out AMA from Hurley, called 911 for an ambulance. Flint Fire showed up, county medics showed up, and eventually an ambulance showed up. Based on that tier 1, tier 2, we send resources for everything. So on that particular night, we had 3 resources tied up in the city of Flint that obviously could have been used for something else, okay? The last thing I will say, and I don't really like to share personal things usually sitting here, these contracts have saved lives. And I have a very personal story that I'm not going to share today, that a contracted ambulance being 2 miles away saved somebody's life. 4 years ago, unknown outcome. So, thank you.
Thank you, Commissioner Shoemaker.
For this, mine are more of a group of questions, so, sorry about that. I see the red light here. Okay. So mine's more of a group of questions I have as I'm sitting here, and if some were covered, I apologize, but, I'm gonna start with my first one. In the proposal, you'd mentioned what a county-managed system is something that some places have went to, and I just wondered what that would look like, kind of give me an idea of a framework, what a county-managed system is, or what it would look like in the state of Michigan, if you
Yeah.
could.
Do you want to talk about what that looks like? Go ahead.
Are you asking how it would look for us
Well,
in general?
give me the general, and then maybe we can elaborate onto the Genesee County model.
Sure. So systems around the state of Michigan that I've seen, you have the 911 center in the same building as the only the only transporting EMS agency, along with like the emergency management and other like first response type program, all in the same building, same structure. And that's like their EMS or public safety headquarters. So in terms of
And county-run ambulance service.
like everything's all under one organization. It's 911, it's EMS, it's emergency management. I'm sure there's other county offices, but I don't pay.
Yeah, and no private EMS agencies,
Right.
right? So just so that you would own an EMS agency with ambulances, that would be a part of the county, is one example that we've seen as well. And there's a wide range of things.
Okay. Well, I'll continue. So it wouldn't be privately held, it would be publicly owned.
By the county, yeah.
And then, do we know how many rigs are actually in the county right now? Or is that part of the transparency thing that everyone would like to see, is to have an idea of the number of what's actually here?
I don't think yeah, we did request that data from the EMS agencies, and that was not provided. And we felt that with the data that we did receive from the state, that was a good start, but that certainly is a consideration that we could look at.
Well, from my standpoint, looking at it is, last night we approved $70,000 in tires for just county vehicles, and that's not even gonna touch it, because it said tires on a nicer vehicle is $1,000, no matter which way you look at it. So now all of a sudden, we got maintenance, wear, tear, the amount of money we have to have, and so on and so forth. And then, is the county billing then the insurance company at this point, or is the county just taking on all that cost itself?
So there are multiple ways that this isn't necessarily the best way or the worst way. It's just a way that people do it. So you can certainly own your own EMS agency, right? You can have your own EMS agency, staff it with your own people, and take on all that liability, pay for it, and bill individuals. You could also contract that out and could pay the agency to provide that service, and they bill the patient and you get the revenue, or that revenue helps offset the operation of that service. There are several different models that EMS could be run. Off the top of my head would be the third service, kind of like what Livingston County has, fire-based EMS, public utility model, private EMS, which is what we're used to here, among others. But there are different ways to set it up. It's not necessarily a one way or best way.
Okay, thank you. I'm gonna continue, because I got quite a few here. Part of the reason we started this, to Marty's point, was we'd had some discussion between different townships believing this is legal, this is illegal to sign a contract with an EMS provider. I've heard both opinions. I've talked to attorneys. What is the answer?
Go ahead.
Looking at me, okay.
Yes.
Yeah, 100%. And we've reached out to the state too.
Yeah,
for
I mean,
their
so
feedback.
people do this. I mean, this is how it's done everywhere else in the state and around the country, right? You have a municipality, you have constituents, and they've had the need for EMS, and they've figured it out. And they have a person or an agency that does that for them. And they've either contracted it, or it's through their municipality, or they've figured it out. I mean, I don't know why it's different here. I mean, we're still, there's some history there. But in terms of legality, I mean, this is done elsewhere throughout the state. So.
You're telling me that the counties can do it, that counties have done it, and then we have municipalities, so obviously, if it was something that big, it'd been challenged at federal court. So basically what we're saying is it's just an opinion, it's not fact, but that it is okay and legal. Okay. My next question is then, when you talk to these municipalities who did not contract with another, with a vendor, why?
Yeah, the ones that responded said that they didn't think that it was legal. That was the biggest takeaway, that they were not willing to put their residents or to be put in a position where they would get sued. That was there were some others, reasons that were provided, but that was the largest one.
I'll just keep going. Has anyone reached out to the state to see whether they would provide an opinion? You know, you would think there would be some leadership from, I wouldn't, because I'm a Republican, but, no, I'm just kidding. No, I'm serious, but the fact is, you think there would be some leadership to give some guidance on this, because since I've been around Commissioner Kuzno, this has been going on a long time, looking for answers for this, and there's a lot of municipalities that would benefit just from the state taking a position on this. Who would we, as a county, if we wanted to have our corporation council reach out to someone at the state level to say, we want to know where you are on this, and could you provide that if we do, so we could actually send something to go, hey, there's a lot of gray area here, and we're trying to figure out, obviously, people are doing this, but
Yeah.
what is the state's position on this? Because you'd think there'd be a law, or, I mean, obviously, Marty's been quoted, I'm sure he was quoted enough, he could probably quote it back. People would quote, because there's certain townships that's very vocal, a lot of the meetings that believes it is illegal. And they can state the statute, and then there's others that say, no, it is. So who would we reach out to?
Yeah, we did reach out to the state because we wanted to get that black and white, like, just tell us yes or no, right answer. We did not receive that kind of a response. It was a very gray response that was provided. So we would be happy to facilitate a meeting, and put you in connection with the folks that we spoke to who are in authority and knowledgeable about that area. We also would be interested in participating in that conversation as well.
I would love for that to happen, and I would clear a day out for it, my schedule, because well, it's so important, it's so vital. So these municipalities, if they are not making the right choice for their residents, if they're sitting there because they're so worried about lawsuits, which we all have to be aware of, it would be great if we could give them a firm answer, because then they could sign up with one of these providers, and guess what, the service could be there. My next,
Commissioner, it may be helpful if you, or if we reach out to one of our state legislators and ask them to get an opinion from the Attorney General on that question.
well, if we could, or if they want to be part of it, I'd love to, whatever. Could we just put that and make it happen? Because I think we've talked about this a million times.
Yeah, we have, and, if I may, Mr. Chair, but I personally don't care if this is legal or not legal. As near as I can tell, it's a big, like they're saying, it's a gray area. But we, as a county commission, we need to help put it to rest, so that there's just one system, and I don't care which one, but I really feel that things need to change, because it distracts the whole system when you go to those meetings and they get off in that, direction, but I feel that whenever you have two systems, it isn't doing our public any good. I think just one system, and I don't care which one, I really and truly don't. You know, there's arguments for both, but, I think that, we, moving forward, the county needs to move 911 in a different direction than what we've been doing for the last, whenever the consortium was set up, that we need to move in a different direction. And, you know, I'm not nearly the expert that, you know, Brian is here. He knows far more than I do. But, you know, we brought in the experts, and I think we should listen to their recommendations. I mean, we got to make the decision. They're probably going to give us options, but we have to make the decision. And that's how I'm looking at it.
If I may.
I was just gonna help,
Go ahead.
maybe
Go
clarify
ahead.
something for you,
Yep.
Mr. So, maybe to help clarify some of the legality issues, or a direction to look, they put at the beginning of their presentation, the Public Health Code, which lays out the allowance for municipalities to contract with a provider. And then the State 911 Committee wrote the Policy E that further breaks down that language in the 911 Enabling Act to address this very thing. So there's 3 documents that could help us, give us guidance to who to talk to clarify that, why 80 other counties have some form of this. And they do it every day, right?
Well, the question would be, one, if we were to do countywide and say we're gonna come up with a countywide agreement, you're gonna have local municipalities that some don't like the provider. So you're gonna have some pushback from that. You're also gonna have some that still, if we can't provide the fact that this is legal, that are gonna say, no, you're squashing what I wanna do. And that's why I wanna get something, and it's so concrete that we go, this is what it is. This is what it says. So these municipalities who are so afraid to do this, why wouldn't you? Other than, leads me to another question, other than signing the contract, is there a cost to these municipalities for entering these agreements?
0.
So, okay, thank you for that, all right, from there, all right. So, but that's what I'm trying to get to is, how do we make them, as someone who's been on a local elected board, like Marty as trustee, there is a lot of doubt in what we do down here at times, but there's also a lot of doubt in what goes on everywhere else, and certain communities obviously haven't signed up to do this because they're fearful, and like I said, I just wanna get to the bottom of it, so we can present them with it. Now, whether that's countywide, I think we're gonna have a lot of pushback, because a lot of municipalities are gonna want their own. There's obviously one, it looks like from your map you gave me, that's what I kept looking at, that is pretty much has the large majority of the county under, service, and then there look like 2 other smaller ones. So, am I correct in that? There looked like there's maybe 3 different contract providers in the county?
There are 2 different groups that are agencies that are on, 3?
Yeah.
MMR, Patriot. What?
And
Oh,
MedStar.
MedStar.
Yeah, because there was a pink, a
Yes.
green, and a
Yes.
bluish color on the
Yes,
map, so that's why I was
yes.
just,
Yeah, 2 preferred, and then the rest are.
Yes, Vienna and
Correct.
Grand Blanc are preferred,
Yeah.
yes.
you color coded it for me, so I can keep up with that, so thank you. Let me keep going here, sorry, I've got chicken scratches here, it takes me a while to read what I've written. Do we know some of the benefits of going with the countywide system compared to letting each municipality choose their own? Are there benefits in that?
I should have stayed up here. Once again, this is just,
Oh, we just want you to get your steps in. We're
yeah,
thinking
it's
of you.
good, it's good. Once again, this is not necessarily the opinion of, this is just my thoughts, okay? So when you are able to consolidate resources, there's an opportunity to improve how the service is delivered. So if you were to say, in Genesee County, EMS is an essential service, And so as a local municipality, you have to figure it out. What that does then is it can make it more difficult for that municipality to innovate or, really to innovate. Whereas if you had a larger scope or a larger program, you have more resources to do things different or to improve how we do things or how we send resources to certain areas. Because you're looking at it from a larger scope. Whereas if you broke it up into smaller municipalities, you're only looking at it from the very, I guess, microscopic level.
Well, here's what I'm gonna say, add to that though, just from another perspective though. And I just want you to think about this. If we were to form something like this and it was governed and oversight by this board, the Out County believes it doesn't get its fair share of services here. And I'm just gonna tell you what I would be fearful of. The local municipalities that, like my, best example, Fenton Township, where I live, is gonna go, why are they stacking so much? Because the city of Flint controls a lot of votes here. And I'm not gonna hide from the fact that it does. And guess what? You'd have more service down here and less out there if we centralize this. And so that's what, just put in your thought process, is if you let everybody down here have a say compared to the local municipalities who can go, I'm not getting the service I need from that, then it's on them at the grassroots level where they're at to make the choice for that provider. So I'm tending to lean towards more that, can we draft a policy, once we find out it's legal, then we draft policy, say you will, can a county draft a policy saying you will sign with the contract with a provider, you know? So those are the things that, is that something that a county has done before, said, hey, you're gonna do this?
I don't know.
Yeah, not that I've seen, but what I love about what you're asking is for more detail and more information, right? Because we want to make a good decision. So once we get this sense of, okay, is it legal, is it not legal, we can move on and then begin to look at the different models and do a comparison of, okay, I mean, we're talking anecdotally based on his knowledge as, you know, being involved nationally with EMS. But let's really look at who's doing what in the communities across the state. And what do those models look like? What are the elements to it? And I think that that's an important next step for us to look at, just to equip us all as we help you make good decisions.
Okay. Well, we made the agreement for the study. When you say next step, is that additional agreement or is part of our agreement now?
That's a really good question, because Heatherland signs up for a lot of stuff, I gotta tell you.
Okay.
But, you know, what I would do is just go back and look and see how accessible that information is. I will say Heatherland Uphold will help you access that information if it's readily accessible. If we decide that we need to do interviews or something more in-depth with, as far as getting perceptions of how effectively those models work, we might have to have further conversations. But if it's just dipping into, you know, what are other communities doing, we got you. That's a fundamental question.
Great. Could you notify us within the next week or two if that's gonna be possible for
Yeah.
you? So we can make arrangements ourselves. If that's not, that we can look into it ourselves and make those insights. You know, you'd mentioned data that, in your presentation, you mentioned data that the stakeholders want. I saw that in the slide, and I was looking through it. And what is the data that they're actually looking for? Because, you know, numbers, just to provide numbers, and we've all seen, you know, there's the numbers, everybody can regurgitate a bunch of numbers and put them out, but what are they actually looking for? What is an important metric to them, or didn't we get that?
Yeah, we didn't go that far deep, but in the interviews, you know what it came back to was response time, right? That's what speaks to someone's heart, but also call types. And also getting into this assessment of the outcomes once someone gets to the hospital. And this is what we see sometimes when folks get the data that they need. You know what it leads to? More questions related to data. Like, okay, I get this picture, but now all of a sudden I want this picture because I want to better serve the needs of my community. So in response, it's response times, call types, but then that would likely lead to more questions and more data that folks would want.
Okay, and then on my sheet of paper, this is my last one. Doesn't mean it's my last question, so just to clarify. with your respondents, you know, that were local municipalities, as far as in the county, do we have a pocket where more came from? Or were there more from townships or cities that weren't participating with a provider in a contract? Or do we have because we're taking in data, and obviously we're listening to this information, but if, let's say someone, like, example, Fenton Township is very happy with their contract they have, their response times they believe are down, complaints are down. So, you know, obviously they're gonna skew this way, but it'd be nice to know if everybody that responded said they were all the ones under contract, or they were the ones not under contract.
Yeah, that's an important question. We weren't able to display the data that would secure someone's anonymity to provide that information.
Gotcha, okay, thank you very
Yeah.
much. Thank you, Mr. Chair.
Thank you, Commissioner
Mr. Chair,
Flo.
just one more real quick, maybe to plant a seed or help with the legality of the whole thing, and I think Mr. Kuzno might appreciate this. So, for the better part of 6 years, I researched, I looked into this, I talked to people at the state, lawyers, everything else. Read the public health code probably 10 times, right? So, with EMS contracting, and a lot of the people I talked to, I compared it with police and fire authorities. Up in Clio, they have one. Davidson, they have one. You have Metro Police. What the fire authority or police authority does, for example, in Davidson, you have the city, Davidson Township, Richfield Township. None of them have their own fire department, but they contract individually, essentially, through an agreement with the Davidson Richfield Fire Department for service. Same thing that the 3 municipalities in Clio do. Swartz Creek, Mundy, with Metro Police. And where that comes in and becomes important is that's what these communities have done for their EMS. They've contracted and designated that provider to be their EMS provider, where they have a fire provider. Most of them have their own police departments, but Metro Police is designated as a police provider for those agencies. Just like Fenton Township, they contract with the Genesee County Sheriff's Department for police protection. And in all the research I did, and a lot of people I talked to, it's pretty much the same thing. Did you talk to anybody? Did you hear anything about that? I don't know what you did or if you even addressed it, but.
Yeah, we didn't at this point.
Okay. I just know that in the years that I've spent working on this, that with a lot of people I talk to, even at the state level with state 911 committee, it's considered that same level. Police, fire, and EMS, even though they're considered a little bit differently at the state level, but if you contract with one and you designate them as your provider, that's it. I'll call it's closer to Burton, but it's in Davidson Township, they don't call Burton.
Yeah.
So, thank you.
Thank you.
Mr. Chair, can I follow up on,
Yes.
are there any additional limitations to your study?
Ooh, that's a good question.
So not having the complete story,
data, yeah.
right? Knowing what happens to the patient, because I certainly as someone who works in EMS on the hospital side and in the pre-hospital side, I want to know how well the system is working. And it was, although challenging, it took a long time to get it, but it's relatively straightforward to see what types of calls certain areas are getting. And it's relatively straightforward to see who's responding, but it's really difficult to drill down and see what interventions are they receiving and what happens to them. Because the second major paper that we based a lot of our work on is the site of the beyond response times, right? So we're not solely looking at the time it takes for you to receive an ambulance after you call 911, but we also want to look at, and what's probably more important, is the quality of care received, and of the couple conditions where times do matter, cardiac arrest being one of them, are we able to get the resource to that patient in a timely manner? And so that was a major limitation, is not being able to readily get outcome data, to know the story, and to really know the quality of care provided.
Yeah, and really the patient experience throughout, right, from 911 to get, and I pulled up the process map so that you can see that there are opportunities. So for as much as there are limitations, there are actually opportunities for us to continue to tell the story of EMS in our community. And one of the parts to that story is the offload, the patient offload. Do you want to describe what that?
Sure. Can we go to the?
That's the one with the interventions. Oh, it's not showing on the
Oh.
screen. Oh, well,
So, okay,
anyways.
so,
We're like, look here.
yeah. So EMS responds, they take care of you, they transport you to the hospital. Nationwide, this is an area of concern, is this delay between the ambulance getting to the hospital and the EMS agents, or the ambulance or the providers getting back into service to take care of the next emergency. So nationwide, this is a problem, looking at what's called ambulance patient offload time.
Yeah, we could go through the whole list, like community perceptions of EMS, like when to call 911. For as much as we created that, the infographic, it would be nice to know, what does community really think EMS does, and when should you call EMS, versus go to urgent care or something like that. So, I mean, there's a whole list of things that we could.
So, based on what I just heard you say, and those are real limitations, right? I understand you don't have 3 years to do the study, but based on what the information that you provided today, and I should say, I just got a text message from one of my township supervisors asking me, he's been asking me a lot, what has come of this EMS study? And they're waiting for us to make a decision on this. And so, having said that, I think, and going back to Commissioner Shoemaker's point about, the potential inequity of the system if we were to consolidate. But it sounds like, based on what I heard you say, that if the data were at their fingertips and readily available, that some centralized system might be able to use that data in order to plan and disperse resources where they need to go.
As far as EMS agencies?
Right, I mean, yeah, there are systems out there that use a lot of different data points, system status management, kind of that idea, to predict where calls will take place based on previous calls and environmental factors and.
That prediction piece is important.
Yeah, yeah.
I think a lot do, yeah.
But the question is, to what extent do they share those predictions and share that data to sort of churn the information so that we can leverage everybody's collective knowledge
Yeah.
in real time?
Yeah, and we do not have, I mean, you know this, that we do not have a centralized data repository for these kind of metrics, but that's the framework that we're providing because it would be helpful. We even had some folks who were under contract who indicated that they only get a report on response times once a year. Whether that's true or not, that's this individual's perception, right? So it's making that information more available, more accessible in a way that resonates with the person who needs to use it.
All right, Commissioner Shoemaker.
Should, in other communities, med control provide?
So the question was, in other
Throw my
communities,
mic
that's
on.
all right, we got
In
you.
other communities, would med control be tracking that information and looking over it and even providing it?
Can you talk
Or is that
about it?
something our med control could be doing, because it's just.
What specific
Well,
data?
some of the metrics that you guys were just talking about, is that something that in another county or area that, med control is actually tracking?
Right.
They're over there at times, and I know they're there because I visited the building, but what are we doing over there? Isn't that something that should be being done over there?
So they have, not speaking for them, but just from my experience from using data, they have similar limitations as us. They also don't have outcome data, so they don't know what takes place after the patient is transported, and they don't know what happens to the patient when they're done with their hospital stay. So they also don't have the complete story.
Do they have the data, though, for response times?
I believe that they submit the data to the state. I'm not sure that there is how much of an intermediary they serve. That's certainly a question that we can ask. Likely what would happen, like the data is a big lift, so that would require some level of additional support from Med Control to provide that.
So like I said, I'm just wondering
Good
what,
question.
what,
Yeah.
what is done over there. Explain to me, is there a statute, obviously there's a statute, I shouldn't say, that Med Control operates under, but what are the services they're supposed to provide once we fund that?
You talk
And if you don't have it, it's okay, but if you could get me that list,
Yeah.
I would appreciate it.
I know they handle complaints, right? What are some of the other things that?
We'll have to look it up.
Oh, okay, all right.
If
We
you,
can provide that in
if
additional
you could,
information.
that'd be, I greatly appreciate it.
Yeah.
All right, Commissioner
They do
Fluid.
support, oh, go ahead.
No, I was just gonna say, so when it comes to the response time piece, every agency has to report to the state. So they all have to, and I think it's kind of a cyclical thing where it does come back to Med Control. 911 also tracks them if everything in that unit's working properly. When it comes to Med Control, it was brought up in the presentation about protocol. So they do set protocol, they do monitor protocol. Those are actually publicly available, because that was mentioned by one of the respondents. They're publicly available right on the Med Control website. Anybody can just get on there and look at them all. So when it comes to the response time piece, yeah, they do have to report to the state, so that data's there.
We were pointed to the state for that data when we requested it.
Commissioner Cousineau.
I just, I'm encouraged by the comments and questions that my fellow commissioners are making. The only thing that I do see happening here, and it's the same thing that's holding up 911, is the discussion on the contracts. That seems to be such a big thing. And we need to, it hasn't been resolved, as I said earlier, we need to maybe resolve it for them. And I don't want to take one side or the other on that, I really don't. And I know, my fellow colleague from Davison there has spent a lot of time on putting it in, and he's passionate about what he's done, and he's done some great things, and I appreciate that. But we need to, and he may be 100% right, I don't know, but we need to put this to rest so that we can start taking care of the bigger picture. Because I'm after the bigger picture, and I didn't even know when I got started with all this that there was even a problem with contracts. That was only discovered later on as I got involved with this timeline of mine. There needs to be a better service. We can do better. Our communities can do better, and I think that's where they're trying to lead us, and I'm encouraged by that. So, and I always like Sean's questions, but you asked a lot of very good questions, and I like that. So, thank you. I'm done.
One last comment as we approach this. If we are looking at a policy decision, an ordinance, whatever it may be, when it comes to addressing contract versus non-contract, legality, what it may be, I think we need to take our time and really do a deep dive on it, because we are not allowed to pass any ordinance that negatively impacts local services. So I think we need to be very cautious in how we address it. Thank you.
Thank you. Thank you to all my colleagues for all of the questions and comments, you all for your presentation. I have an ocean of comments and questions and concerns, but given the brevity of time, would like to conclude at 6:30 and really appreciate you all hanging in. This has been a high priority for our board, and certainly grateful and thankful that you all are here to answer these questions. So I'm gonna just fire off just a couple things as we conclude. I felt this way before I was given the honor to serve on the Board of Commissioners, and it's even more so affirmed, even in this discussion, that to me, this entire situation in terms of EMS, I can go down the list of a lot of things that's already been mentioned. You know, the dispatch challenges and availability of response times. I mean, I could go down the entire list. I think from a public safety standpoint, it's the greatest threat to our county. I think it's the greatest issue, greater than someone getting carjacked, greater than somebody getting shot. I believe that this is at the top of that, and that's with no disrespect to the value of life and the loss of life that have happened too much at times and in certain areas. So I wanted to say that. The biggest question that I have as a county commissioner in the area is really, you know, I want to better understand the extent of our authority and the types of things and actions that we can take to impact this situation. There's so many things that we've heard, so many different things that are captured in this study, and I wish I could just hit a button and it spit out, you have the authority to do this, 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 and this, and this is the realm of possibility in what you can do, because I think this is a starting place, but I think it's important that we understand that, because I think it'll help us to focus in this mammoth of a challenge on what it is that we can do and what areas we can impact. So that's something I'd like to know, and something I'll ask for our attorneys to look into, and maybe they'll ask even whoever they need to get to the bottom of that. I think we need to know that. A couple of other things, you talked about the consortium. I have my concerns. You talked about the 911, the building that they moved to. I had mentioned to Josh recently that I'd like to have them come back in here to present to us and give us an update. I know you gentlemen sit on it, but the leaders of that consortium to come back and talk to us about that, because I'm not happy about that. We approved those resources, and it was contentious to a certain extent. There was a lot of political posturing and such, folks suggesting that we were being irresponsible and so on and so forth, and that wasn't even the case. We were in the 9th hour when they brought it to us, after they made a decision as to what they were going to do, and then come to find out there had to have been another plan. I'm not happy about that. I share concern there. So I'd like for them to come back in and give us a report, because we approved that max. I think we went to the max. Did we go to the max?
Yeah, the maximum.
Okay, so we went to the extent that we did, and it was based on everything that they brought forward. And what has happened since then doesn't look like what they shared. And then I also have concerns, Commissioner Cousineau on board, about purchases that were made with those resources. There was some discussion about some equipment for different municipalities, you know, that they were, had been offsetting some costs and so on and so forth. I don't remember all of the
Talking
details.
about the radios.
Okay, the radios and stuff. And at that time, we had some discussion. I know I raised it, and maybe others, as to whether or not that was their responsibility, not whether or not the municipalities wanted them to do it or that they had done it before, but if it's something they should be doing. And I believe, if my memory serves me right, I was one to suggest, I don't necessarily want to see that increase going to that. My understanding is that some of the increase has been used to double down on that effort. I'm not happy about that if that's the case, but I think they owe it to this body as a group to come back to us, to give a report to us, just as others that have millages and stuff that we collect and then pass on and so on and so forth. So I just want to say that, because that's something I want to follow up on. Changes at the 911 consortium. I didn't know much about the consortium, and but the display and the advocacy and the rallying and you know, whatever you want to quantify it as around that increase was concerning to me. And the approach was concerning to me. The players were concerning to me. So I'm concerned about the politics that are at play and how folks on that consortium operated in a way that it seemed to me as bullying of this body and a strong arming of this body to get us to come to the conclusion that they wanted us to come to. And so when you talk about, hey, we need to look at what that looks like, I'm all on board. You're not gonna have an issue for me. But I also understand the political ramifications because I don't have the political dynamic in my district as it relates to the consortium because of, 911 and so on and so forth, that others may have in their district in terms of, the individuals who are engaged in the consortium or a part of it from the different. So I'm also sensitive to what that means for the varying districts based on who the players are. So I just want to say that. Another thing I want to say is I am very, very concerned about what you mentioned as ghosting by the contracted EMS services or companies where there's the disabling of the AVL systems. I think that should be illegal. I think that, they're operating and doing the nature work that they do. That's something I'm interested in, even lobbying, elected officials to see what they can do about that because it's not right. If they're on the job, whatever company, whatever employees, and they have the responsibility to be respondents of those of dispatch, but they're shutting off their location, thus, taking them out of line of being selected. I mean, that can cause delays. That can cause the loss of life because maybe there's a vehicle, a unit around the corner, but they don't know it because they turned the system off. You understand what I'm saying? And so on and so forth. So that's a major, major issue in an environment where there's already issues with the availability of units and contracted versus not contracted and so on and so forth. And if the public knew how many units were available at individual given times and certain portions of the county, I'll just say it that way, the public would be alarmed. And so that's a huge piece. So I guess at least I'll ask one question as we conclude. What do you all suggest as it relates to the ghosting by contracted EMS services disabling AVL systems? What kind of concerns were raised by respondents to the request for comment or what have you? What did you hear? Can you expound on that more?
Yeah, for sure. That did come up a number of times, not only in the survey, but also as the interview were going on, and folks just wanted more transparency. And so when we talked about transparency, it wasn't just data, it wasn't just protocol, it also was knowing which, how many ambulances were available and where they were.
Mm-hmm. Thank you. And then I'll conclude with this. When we talk about the dispatch the dispatch challenges where too many units are being sent in multiple units and agencies being sent to one call, I've seen it so many times. We had an individual at our church recently who had a medical emergency. Excuse me. And, we didn't know what the emergency was. They lost consciousness and of course, there were some medical professionals who were on site that were part of the fellowship of our church, so they were able to assess and attend to this person. But there were fire trucks and multiple units and so on and so forth for one person. So, for me, the question is, well, is there a concern that this unit may not have the expertise, they may not have the equipment, thus it's necessary to send multiple units, that kind of thing? Or is it just, which happens, just everybody kind of showing up and kind of aligns with being at the hospital, dropping off a patient and just hanging around shooting the breeze instead of getting back into service, just killing time. I mean, I'll stop there because I don't want to be offensive to public safety in general because I've seen it. It's a tire in the road. I'm going to sit here as a police cruiser and just sit here for the next 3 hours and I've talked to officers, so I know that things happen. All of those things lead to the lack of accountability and the need for centralized accountability. So I think you talked about it a little bit, Commissioner Cousineau. That's something else I'm very, very interested in, and that takes me back to where I started in conclusion, is understanding the extent of our authority and the types of things and actions that we can actually do to address these things. Once we understand what that is, then we can target the accountability. We can look at whether or not we can force people to, you know, have contracts and so on and so forth. Lastly, I'll say this, some of my colleagues know this, so I work at the UAW, serve at the UAW, and in the beginning of my career, I was a servicing rep in what we call Region 1D. It's 9 geographical regions in the United States, and because of the density in Michigan, there's 3 regions here. So I was a servicing rep, negotiated contracts, represented various members, mediations, arbitrations, et cetera. And one of the units that I represented back in 2010, when I first became a servicing rep, was Stat EMS. And I think at the time they had like 400 employees. So a lot of conversations about, you know, revenues, the mix of their work, and because obviously I'm trying to get resources for the members. But I heard a lot of challenges in this work, but I also learned firsthand a lot of, let me just say it this way. Just because individuals are in a sensitive work does not mean that they are responsible as it relates to the sensitivity of the work. And so, so I know that there are major challenges. And in the area of accountability, to be able to have a space that everybody's accountable to, that's monitoring this and that, and there's reportings of this and that, and check-ins of this and that, and policies put in place of this and that, I think will go a long way to help clean up what could be barriers to this entire equation being a whole lot better than it is. Because it's the things we need to do, but it's the challenges with what is already happening. That's what I have to say. If there's no other comment,
I just have a question. So what's the next step in terms of, I mean, the consortium are they having another meeting coming up soon? And what is there a plan, if any, to share a similar report with them? Or what do you think needs to happen next?
You asking me?
Either one of you.
Okay.
Yeah.
I think we have a plan that rolls out to everybody.
We just to, as far as I know, their report has just been rolled out to us.
Right.
It hasn't gone past us.
Credit.
But yeah, it started with us, and that should probably be sent out, and to, I would think, the members of the consortium, and more importantly, the staff, you know, Tim Jones, et cetera. It should be sent to them. At some point in time, it should be, you know, explained to them too, whether you could, you know, put them all together. I mean, at times we haven't in the last year and a half, but there's been times even getting a quorum, and, you know, so to get everybody in there, you know, so I don't know how to disperse that information. But as far as us moving, that should happen, but as far as us moving, I think we should set a time to get back with them and have another meeting, and I would say nothing less than 30 days, or anything more, I should say, than 30 days, to do a follow-up, and we should start making decisions. You know, I know that you mentioned you need to know your legal limitations and et cetera, and you know, I have that, and I know corporate counsel has it, and I thought I had dispersed that to everybody, you know, probably before Brian was here, but I don't really remember, but that is available through our corporate counsel, and everybody should probably take a look at that. But we're the ones that set up the consortium. I mean, we're the ones that had the legal authority to do that. And so we do have the legal authority to change and move forward and try to make this community better. So, but I understand your concerns, so read it. But yeah, I'll leave that up to you and staff to follow through with a, follow-up meeting, but I would like to, I would think we should stay on top of this. I mean, I've personally been sitting on the edge of my seat for 2.5 years, waiting to get to this point. But now that it's out, I think we need to stay on it until we, may take a few months for us to debate it and make a decision, but I think there should be something with them involved within 30 days.
Mr. Chair, just a general question. Not to be offensive to anybody, but are we talking about the results of the EMS study and the recommendations that they made as far as improving the system, or gutting, reforming, doing something with 911 and med control? Because I think, in my opinion, we're talking about a couple of mutually exclusive things here. And what they presented in their study about 911 was just improvements to their current operations. So I caution us that I think in my opinion, we're talking about two different animals here.
I think, I can appreciate that. I think we need to have, because we received the information to ask questions, I think, and I appreciate the information that you said is available, so maybe we can get Brian or whoever to send that back out to everybody, anybody who wants it, maybe we just send it to everybody, but I think we need to have a maybe more in depth, now that we have the information, the presentations, I think we have them in our email, and I think we need to have discussion like kind of 911 about the variances and what we want to do.
I just don't want to conflate the issues if we're talking about the study versus the consortium.
Sure.
Are they mutually exclusive? Are they intertwined? Whatever. But I think their study presented just some upgrades to operations rather than a restructuring.
May I make a recommendation
Shoemaker,
for
I'm
the,
sorry.
thank you, Mr. Chair. I think what we need to do is give everyone, I don't know, do we need to vote to accept what they have and send it out at the next meeting? Do we need to do that, or we can just send it out?
I don't think,
There's other projects we voted for, though, to release, so I just want to make sure we're doing it correctly, so.
what's your question again? Ask the question
Is,
again.
the fact is, do we need to take what they provide us, the study they've done, which we ordered, but do we need to vote to actually release it? To accept it and release it?
Because we ordered it?
We ordered it, but, with some of these things before, when we've ordered this, and Commissioner Kuzma, remember, we've done some of these proposals before, and then we vote to accept the recommendations and then release them. So I just want to make sure, maybe we don't, we can just release them, I don't know, just find out, that's
We
all.
don't have corporate counsel sitting
Yeah.
there right now.
I mean,
if
it's
you
kind
could-
of
if you
public
could
now.
ask-
They just had it on YouTube for 2.5 hours.
Well, but their proposal was out there, not the study. Do you see what I'm saying? So I just want to make sure we're doing things right, because there's a lot of people are going to be heated on us
Maybe, yeah,
or after us.
maybe to be on the cautious side, we should do a motion to accept that, because, we did order it, they did present it, and then also do a motion to release it.
Yep.
And to do both of those, just to be on the cautious side. Now, as Commissioner Fallown just reminded us, we have been on YouTube for the last, whatever it's been, 2 hours. So it's already out there, but.
The proposal, yeah.
But,
Or their presentation.
we're, this is a board meeting, and we're conducting the public's business at this point in time. So I think that would be prudent to do what you're.
Is that your motion? I'll second it.
I will make the motion to accept the report.
Okay, and I will second it.
All right, it's been moved by Commissioner Kuzno, supported by Commissioner Sean Shoemaker, to accept the EMS preliminary report. Is there discussion? All right, seeing none, all in favor, aye.
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 All opposed, nay. All right, motion passes 5-0.
Okay, then I will make a motion to release the report to the public, and in particular, the 911 consortium.
Support.
All right, it's been moved by Commissioner Kuzno, supported by Commissioner Beverly Brown, to release the report, and what's the second part of that you said?
To release the report to the public and in particular the 911 consortium.
To the public and
911 consortium.
911 consortium. Okay, thank you. All right, so it's been moved and supported. Any discussion? Commissioner
Yes.
Flewellen.
Do you guys already have a plan in place for a public rollout?
We were going to do that at your discretion, however, you feel it would be best to share it.
Okay, second part of the question, are you willing to come to the 911 consortium meeting and present this to them?
Sure.
What do you think about, this is before you ask the question, before you ask that question, what do you think about doing the town hall here? Maybe
Well, I
downstairs
think
on the
that's what
first-
we originally discussed a couple of months ago, was they would present it to us here, and then over the course of 30, 60 days, I think it was, having town halls around the county to present it to the local municipalities, local elected officials.
That I forgot.
Yeah, we discussed that part of it too, so, you know, if it's here, whatever it may be, obviously your 911 consortium consists of municipal leaders from around the county, so that may be a good opportunity for two birds, one stone kind of thing. I don't care where we do it, I just think that this group should be the ones that present it to them.
So what's your thoughts? Let's flush it out just a little bit as we prepare to leave. We have the space downstairs. Commissioners can be here, 911 consortium can be here, whoever else we think should be here, put screens in the downstairs in the room, or do it in here. I mean, this place has a larger capacity for more chairs in here, and just do like a big town hall. And then there's one person that says sometimes you gotta drive past the scenery more than once to take in the full view. I wouldn't be opposed to hearing the presentation again, because there's a lot of information and it rolled pretty fast. So what's your thoughts?
We have a motion on the floor. Let's do that.
Yeah.
And then discuss these details, you know, after
Okay.
that.
And I was just discussing it because of the question you raised,
Correct,
you know,
yeah,
during
I
the thing.
understand.
So let's, if there's no other discussion on this particular motion, no other discussion? All right, okay, all in favor, aye.
Aye.
All opposed, nay. Okay, 5-0, motion passes. All right.
Now, you,
I think the idea, I think, is a good one. I think, do we have more capacity downstairs?
So we do, in this, according to our team, is that we have the room downstairs, you can open the doors, you can cast on the screen in the hallway
Sure.
as well, and you can add additional chairs out there. So it can make for, well, we have some
Yeah.
cake and punch or what have you, but we'll have increased capacity for leaders to engage in that kind of thing. And one of the reasons why I suggested is, because it'll give, well, anybody can go out there for a meeting too, maybe, but it'll give like elected leaders and 911 consortium and all of us an opportunity to hear what folks
I mean,
have to say.
I think if you target the 911 consortium and say, hey, we'd like them to present this to you, open it up to other elected officials or the public, but do it as a town hall type thing. I think if you do it in here, we're up here, they're out there.
That's why I suggest downstairs.
I think that maybe that we should have them present to the 911 consortium, just them first.
Just them separately.
And then open it to the public as a town hall.
The next general membership meeting is December. So,
Okay, there's nothing in October and November.
just executive board.
I forgot.
Yeah.
Yeah, it's a weird system.
Yeah.
I said it both, and I don't pay attention to it.
Right, yeah.
Brian, would they
call- would they
call a
meeting for special this? meeting.
Would they call a meeting for this, do you think?
You'd have to talk to Fred Thorsby over in Flushing Township, chair of the consortium, to see if
Call a special meeting.
he'd call a special meeting to hear this presentation.
Well, I think it's.
And he might, but the danger in the special meeting is, do you get the quorum? Do you get the people there? But it's worth asking.
Doesn't hurt to ask.
Yeah.
No, I think it should be moved up, because we've waited on this data long enough.
Yeah.
Now, it's time to really put it in overdrive. This was on our list of things we wanted to accomplish when we started, you know, with our workshops. Yeah, and this is still top priority, so I would like to see, as long as you guys are available to help us through this process and present what you found, I would like to ask him, and I don't know who's gonna do, who we would have do that, so let's clarify who's gonna actually ask him.
I don't have a problem with asking Fred and ask him to call a special meeting on when is the next regular
The next
monthly
regular
meeting?
membership meeting would be December.
No.
General, the next executive board
executive.
would be October,
October.
first Tuesday, I believe, of October.
First Tuesday?
Yeah.
Okay. Or would you guys be available at 2:00?
First, I mean, absolutely, he's the one that is difficult, because he could be saving lives at the hospital.
Yeah.
But,
Well, I'm asking him to
Be
save
the 7th of
multiple
October.
lives on that date.
yeah. You're out of town.
October 7th, okay. They can call a special meeting anytime.
Yeah.
That would be a good day because they're gonna be there, but,
Yeah, you wanna get us a couple days so we can,
Yeah,
Well,
I think
yeah.
it's gonna
Talk to 'em?
revolve around
Yeah,
you,
yeah.
right now, when you can do it. But I will call, Fred, soon, tomorrow or tonight, and ask him if he would be willing to set up a special to be determined
or
date.
does he want to do it as part of the town hall here? See if he can get his members here for that,
Correct.
you know?
Yeah.
that
Give
may-
him options.
Yeah, sure, absolutely.
For coordination's sake, who should I contact or be in contact with to get all the schedules in order?
So Josh Freeman, our
Okay,
Director
perfect.
of Administration,
Yeah, I
you
do.
work with Josh.
He's our fall guy.
Okay.
He does
Right.
everything.
I think it's important too, to notify the city of Fenton this is going on. Because they're not a part of the consortium, but they're gonna be, potentially could be affected by this.
get the date, let me know the dates and
Yeah.
I'll
Yeah.
ask Mr. Freeman to reach out to
Well, I think it has to work with these
That's what I'm
fine
saying,
folks and the 9 of us.
That's what I'm saying, get the dates and.
Yeah.
Get your dates first,
Yeah.
and then we'll go.
Knowing that the contract issue is a hot topic, would it be helpful to get that answer from the state before we have the meeting?
ASP.
Or, I don't want it to delay the meeting, but we know that it's gonna come up, and it's a real barrier.
It would probably help, but good luck.
Well, I know, because
You know
that's
what
what
I'm
we
saying?
ran
To pin down
into.
the state to say yes, absolutely. There's already 2 different opinions in the county, so.
I know, that's what we ran into.
I would put the
too.
request in, and if it's done by the time you get them to the meeting, great. If not, we're just gonna have to look at these people and say, we've attempted before, we've attempted after the presentation, and this is what you get from the state. Call your state representative and ask them to put pressure, I don't know what department it falls under, but ask them to do it. And maybe they could create some laws, and we should invite our state all of our reps. We have
Yep.
9 we have 9 that contact the county.
Yeah.
They should be here for it also.
Well, and honestly, I don't think, just my opinion, I don't think the legality piece is the important part of the whole presentation.
No.
They're doctors and what have you. They're not lawyers.
Yeah, you're right.
They can get the legal opinion,
As
But
soon
we've-
as possible, but it doesn't.
right, but we've already had 2 different ones in this county, right? So if they get a third, but that's, to me, that's not the important part of the whole study presentation.
So you just, will you let me, I know you'll let Josh know, will you let me know what they said, how they want to handle the meeting and that kind of thing? Either one of you, yes.
Yeah.
Yeah, okay, that'd be great. And then, I neglected to mention that, Commissioner Wayhill would have been here. He kind of fell ill this afternoon, so he's home in bed. Commissioner Avery as well, so you know, had some, a challenge come up that he had to have. And Commissioner Flewelling, Getzinger. Commissioner Getzinger as well. So we would have had a full house today, but some things came up. It's important to us all. Thank you for your time. Have a wonderful night.
Thank you, thank you.
This meeting is adjourned.